Oh, there we go. Okay. So just by way of disclosures, just so everybody's aware, I am on an advisory board or do some consulting for Decipher, the company that makes vimseltinib. Okay. So before we jump into all of the data and the information, I just want to make sure we're on the same page about clinical trials. Okay. So I'll talk a little bit today about different clinical trials. And so there are 4 phases of clinical trials. We'll focus just on the first 3. But a phase 1 trial is a trial where we're not trying to figure out if a drug works or not, right? A phase 1 trial is purely to look at safety of a drug and to figure out a dose, right? So these trials are small, right? A small number of people, oftentimes they get different doses, and then you try to figure out which dose is safe to give. And then that's the dose that will basically move forward into other trials. Okay. And then there are phase 2 trials, which the idea behind a phase 2 trial is to see early signs of whether a drug works or not, right? So you give the drug to a relatively small number of people at a dose that you've already figured out, right? In the phase 1 trial, you give them the dose in the phase 2 trial, and everybody gets the drug, right, in a phase 2 trial. And the idea is just to say, okay, we're going to set a cutoff and say if 25% of people seem to get some, response to this drug, we're going to move it forward, right? So you kind of set the cutoff ahead of time and you give the drug. Okay, and so that is a phase 2 trial. It's usually kind of a medium size. Obviously on this slide, it's saying 100 to 300 people. That's not a thing in TGCT, right? There's just not enough patients for that. But this is, just sort of applicable generally. So this is sort of a medium sized trial. There's no comparison, right? Everybody gets the drug and you just see whether or not it seems like it's effective. Okay. And then if it is, then you move on to a phase 3 trial, right? And so a phase 3 trial is really what has to be done to get something approved by the FDA, right? The FDA very rarely approves a drug based on a phase 2 trial. It has happened, but it is very rare. So most of the time you have to have a phase 3 trial. So what's important about a phase 3 trial is it's a lot of patients, but also there's a comparison, right? So you're saying, what's the standard of care, right? And then we're going to add the drug to that, right? So let's say in breast cancer, you're comparing chemotherapy plus a new drug versus chemotherapy alone, right? And we'll talk about it in the trials for TGCT, what the comparison is, but basically the idea is that you're comparing the drug to something else and then deciding whether or not people are responding. Does it seem to be safe? Is it effective? Right? And so a phase 3 trial is considered kind of the gold standard, right? And really what needs to be done. Okay, so with that being said, TGCT has been around a long time, right? But we did not have any FDA-approved medications until more recently, right? So, but prior to that, we were taking care of people that have TGCT, right? And we were treating them. So what were you treating people with prior to 2019, right? Imatinib, right? And so I'll tell you a little bit about imatinib in a second. Nilotinib, and then people were basically being supported, right? Pain management and things that Dr. Copenhaver was talking about. And then people were getting surgery, right? So imatinib, sorry, this looks a little bit fuzzy, but I'm sure all of you are aware, and maybe it was reviewed earlier, that it's the CSF1 pathway, right, that is active in TGCT. And so all of the therapies are targeting the CSF1 pathway and trying to calm that pathway down, because that pathway not only gets the TGCT cells to grow, right, but it also recruits all of these inflammatory cells, right, from our immune system into the tumor. And that's really what causes all the pain and the stiffness and the issues, right? So this pathway is doing kind of 2 things. And so the idea is obviously block this pathway and hopefully people will get better. Okay. And so imatinib is a drug that's been around a long time. It was not approved for TGCT, right? It was not made to treat TGCT. It was actually made to treat a different disease. But what was found was imatinib actually does a pretty good job of blocking CSF1, right? So people were being treated with imatinib. And so there has never been a trial of imatinib and TGCT. Okay, the data comes from a retrospective study, right? So all the clinical trials that I talked about, this is saying, okay, we're going to get a group of patients together. We're going to treat them in this way, right? We're going to monitor, we're going to check scans, do all of this. This is a retrospective study, meaning people had already been treated with imatinib, right? But then somebody said, well, to me, it seems like it works. Does it seem to be working elsewhere? So the idea behind a retrospective study is basically to gather up all the data of the people who have been treated with imatinib and see, did they seem to benefit or did they not benefit, right? So this is actually 62 patients, the data from 62 patients that were treated with imatinib across Europe. So this was a European retrospective study. And it did show that about 30% of people responded to imatinib. And so this is called a swimmer's plot, right? It's a little bit busy. I don't know if you can see my pointer here. Yeah, it's a little bit busy, but basically each one of these lines is a patient, right? And the blue means that they were on imatinib and the red means they're off imatinib, right? So if you follow one of these patients, right, you can say, okay, well, this patient was on imatinib, and this is actually a pretty long timeline. So if you look down at the bottom, this is years, right? So these people are on imatinib for a long time, and then maybe stopped responding or got surgery, right? They'll tell you all the reasons here. But this study was actually important because it showed that imatinib does have efficacy, right? Even though it wasn't set up to inhibit CSF1, but it does work. Okay. So then the idea was, well, if CSF1 inhibition seems to be working and imatinib's working, why don't we actually make a better drug, right? Why don't we make a drug that can actually target CSF1 more specifically? So everybody was excited when this trial got published, right? So this is the Enliven trial. Okay. So this trial is the one that basically led to the approval of pexidartinib. Okay. So this is a phase 3, right? Randomized, double-blind, multi-center trial, right? So this is considered kind of the gold standard, right? Because double-blind means the doctors don't know who's getting the medication, the patients don't know who's getting the medication, right? It's randomized, meaning I'm not deciding whether my patient gets drug or not, right? It's happening in somebody's computer, right? Somewhere separate from all the sites, right? It's like a third party that randomizes the patients to get drug or not get drug, right? And then in this trial, so it's phase 3, so it has to have a comparison group, right? So the comparison group here is placebo, okay? So basically no treatment, right? Or a sugar pill is the comparison here. Okay, and this was performed, this trial happened at 39 sites, right, in the US and internationally, which is great because then it's more representative of the general population, right? Instead of doing a trial just at one site, right? The more sites, oftentimes the more diverse the population, so it's often more applicable. Okay. So in this trial, who was included? So to be included in Enliven, you had to be at least 18. You had to have a biopsy that showed you had TGCT, and then you had to have advanced disease, okay? Meaning that you either couldn't get a surgery, or if you had a surgery, it would actually be worse than having the disease itself, right? The complications of the surgery. So you had to have advanced disease, and then patients had to have symptoms, right? Because I'm sure a lot of you know that just because you have TGCT doesn't mean you need treatment for it, right? It's really, is it impacting your day-to-day life, right? Is it changing the way that you live your life? Are you not able to do the things you want to do? So people had to have symptoms in order to be included. And then they had to have a tumor that could be measured by MRI. So in this trial, I know it's a busy slide, but the idea here is once you confirm that people met all that criteria, then they were assigned 1-to-1. So half of the patients got placebo, half of them got pexidartinib, okay? And in this trial, they actually did the dosing a little differently than we do it now. But basically, they first started with a higher dose and they went to a lower dose, and then this was compared to placebo. And then at the end of 24 weeks, for the people who had placebo and weren't benefiting, then they could switch over and start taking pexidartinib. Okay. And one thing that this trial did that is really important is they looked at what are called patient-reported outcomes, right? Because it's not always important for the tumor to shrink, right? It's great if the tumor shrinks, but realistically, what we're trying to do is alleviate people's symptoms, right? Get people's quality of life better. So the idea here was, let's take a measure of how much pain do people have, right? How stiff is their joint? You know, how is it impacting their day-to-day? And then look at that change over time. Okay, so they did that in this trial and the subsequent trials too. All right. So these are the patients that were included. So in total, there were 61 patients included in the pexidartinib group, and then 59 people got placebo. And you can see that this is a relatively young group of people, right? The average age was about 44, 45. Okay, it was a little more than half were women. The majority of the patients were white, and the majority of them were treated outside of the US, mostly in Europe. Okay, and the majority of patients had disease in their knee. And then one thing that I want to point out is a lot of these people had already had a lot of surgeries for TGCT and had to have treatment before, right? So this is how many surgeries did people have? And you can see, 20% had had one, and some people had had 3 or more surgeries already for their TGCT. Okay? And then a group of them had already received imatinib in the past. And the one other thing I want to point out is that a lot of these people, about 60%, were taking pain medications every day, right? So we're very symptomatic from their disease. Okay, so what are the results of Enliven? So this is called a waterfall plot. So again, each one of these lines is a single patient. And so this red line is basically the line in which they said that your disease has basically shrunk, right? The tumor shrunk if your tumor drops below that red line. Okay, so that was kind of the cutoff line. So as you can see, and then this is the percentage. How much did the tumor shrink? And you can see for some people, this is 100%, right? So about 9 people had their tumors completely go away while on trial. And then about another 15 had what's called a partial response, meaning they dropped under the red line, right? But they didn't make it all the way down to 100%. Okay. And then another 24 had their disease stay the same size. Okay. And then you can compare this to the placebo group, right? Where, as expected, nobody dropped under the red line. Okay. So this is the patient-reported outcomes part. And I know the slide's busy, but just to give you the general idea, they were basically just saying that people's range of motion got better, right? That people were able to function better. The joint was less stiff. People had less pain. So overall, people's quality of life improved on the drug, right? And not everybody had their tumor shrink, but a lot of people still benefited from a quality of life standpoint. So now the important part, right? What are the side effects, right? Because I always tell people taking pexidartinib or these drugs, right? It's not like taking a baby aspirin every day, right? I mean, these drugs have real side effects and can really impact quality of life too, right? So what was seen in the trial, some of the most common side effects are the hair color changes, right? So people's hair can get lighter and skin too, right? Can get lighter. And for some people, it can even get to the point where it's white, right? Which can obviously impact people's, appearance and their quality of life in that way. And then it causes some GI upset, right? So people can get nausea, they can get diarrhea. And then the one thing that almost everybody complains about, they say 54, I think it's closer to 100, is fatigue, right? People feel tired when they take this medication. And then there's some swelling that can happen around the face as well. Okay, and then to me, this is a big problem that I see, which is called dysgeusia, which just means change in taste, right? So that can have a big impact on people's quality of life, right? If food doesn't taste the way that it used to, right? So those were kind of the day-to-day side effects. And then the other aspect of this that a lot of you I'm sure have heard about is the liver function. Okay, so the liver function on this drug, right? So these are our 4 different measures of liver function, and people basically had these go up or go into the abnormal range, right? And so we'll talk a little bit more about the liver issue in a bit, but I just wanted to draw your attention to that. So based on this data, the FDA did approve pexidartinib in August of 2019. Right? But they said, so in a different trial, not this trial, right? In a different trial where they were actually using higher doses of pexidartinib to treat other types of cancer, there were 2 patients who got higher doses and basically had liver failure. Okay? And one unfortunately died of liver failure and the other one needed a transplant. So because of that, and because they saw those numbers going up in this trial, the FDA said, we agree that there needs to be a drug for TGCT, right? This drug appears to work and it appears to be overall safe, but we're going to require what's called a RIMS program, okay, which is a risk evaluation and mitigation strategy. Okay, and there's a handful of drugs out there that require this, but the idea behind it is everybody needs to be informed. Okay, so in a RIMS program, I, as the physician, have to register with the program and do a training, right, where I have to go through the data and make sure that I understand that there is a risk of liver failure, right, with this drug. The patient also has to log in at a website, right, and go through this training and make sure that they understand that there's a risk of liver failure with this drug. And then everybody has to agree that the labs are going to be checked regularly. Okay. And at the beginning, they have to be checked once a week. Okay. And then because the RIMS program requires a lot of monitoring, right? People can't just get it from any pharmacy, get the drug, right? You have to make sure that you're meeting all the criteria. So because of this, the drug's only given from one pharmacy. Okay. So those are kind of the caveats about pexidartinib in the RIMS program. Okay, but this drug was being used for quite a while, and a lot of us were seeing really great responses, a lot of effects, a lot of good effects, and a lot of improvement in quality of life, right, that we weren't seeing previously. So shortly thereafter, this trial was published. So this is the MOTION trial, and this is the trial that got vimseltinib FDA approved. And again, it is a phase 3 randomized double-blind placebo-controlled trial, right? And some people will argue that maybe placebo is not the most fair group, right? Because normally we compare to standard of care, right? So some people say, well, maybe it's not fair to use a placebo group. But at the time this trial started, pexidartinib actually wasn't FDA approved, right? So they didn't use pexidartinib as a comparison. So again, it is placebo controlled, which I do think is fair for TGCT, right? Because as you can see, some patients who didn't get any treatment, it's not that their tumors grew a huge amount, right? Oftentimes this is sort of a slow growing tumor, and it's more the quality of life that's a problem, right? So this trial was performed at 35 sites in the US and internationally. Okay. And again, very similar, right? It's basically the same group. The only thing that they mentioned was you can't have had pexidartinib to go on this trial. Okay. So if you had received that drug, you were not able to go on the vimseltinib trial. And so this is the response rates, right? So 83 people. So this trial is a little bit different in that people were randomized 2 to 1. So 2 people got vimseltinib and 1 person got placebo. Okay. And so there were 83 people who got vimseltinib and 40 that got placebo. And similar to the other, plot that we saw, about 4% of people had their tumors go away completely. 29 had their tumors go away somewhat or shrink considerably in size. And then some had their tumors stay the same size, about half. Okay. Okay, and then in terms of side effects, again, we see a lot of facial swelling with vimseltinib, right? So that's periorbital edema, just means swelling around the eyes, right? So some people wake up in the morning, the eyes are, the area around the eyes is very swollen, and then the face, swelling as well. And then a lot of people feel tired, again, when they're taking this drug. And there was some nausea, headache, and other things that were reported. So again, this is the results of this trial. Sorry. These are the results of this trial. As I mentioned, 4 people had a complete response, 29 had partial, and 40 had their disease stay the same size, okay, compared to placebo. Okay. And then again, they also looked at these patient-reported outcomes, right? Because we all know how important these are, right? How much did this drug actually affect people's quality of life and their ability to use the joint? And all of these things improved, right? Similar to pexidartinib. People had less pain, they felt better, they were more active, their quality of life was much better. So because of this trial, the MOTION trial led to the FDA approval of vimseltinib in February of 2025. So now we have 2 FDA-approved drugs, which is very nice, but now the question is, which one do you use, all right? And I want to go into my next slide by cautioning that the #1 rule of clinical trials, or when you're making decisions based on clinical trials, is don't make cross-trial comparisons, okay? You cannot compare one trial to another trial and say, well, 20% responded in this trial, 40% in this one, this drug is better, right? Because there's just a lot of bias and a lot of issues with doing that. So you really have to have a trial to compare things head to head, right? Which is not going to be done, right? And hasn't been done because both drugs have been shown to be effective. So I do want to make a comparison though to between pexidartinib and vimseltinib. So just to point out some big differences between them, the dosing is a huge difference, right? So pexidartinib has to be taken twice a day, okay? Whereas vimseltinib is taken twice a week, okay? And then we talked about the RIMS program, right? So there is a RIMS program for pexidartinib that it is not required for vimseltinib, okay? And that's because we did not see the liver function tests going up a lot in vimseltinib, okay? There were a small number of people who had their liver function tests go up, but not nearly the same number as in the pexidartinib trial. Okay, so we do think that from a liver standpoint, vimseltinib doesn't seem to have some of the liver toxicity, okay? But the most common side effects are slightly different between them, but there is a lot of overlap. So with pexidartinib, the hair color changes are pretty significant, and a lot of people experience that, right? The fatigue and then the increase in the liver numbers were the three most common side effects by percentage. Whereas vimseltinib, the face and eye swelling, right, was reported by a lot of people. And then the feeling tired, and then itching was reported by a lot of people who took vimseltinib. And then I caution you about the response rate because I shouldn't try to compare them, right? But I do want to make the point that they're similar in terms of their response rates. Okay. And I know this number seems low, right? 39%, 40% of people responding seems low. But just to clarify, this number means their tumor shrank, right? That either you had a complete response or your tumor shrank below that red line. Okay. This does not include all the people who had their disease stay stable, right? So both of these drugs actually have much higher what we call disease control rates, right? So it's probably more like 70, 80% of people had their disease either stay the same size or shrink, right? But we tend to compare response rates or talk about response rates, but that's actually shrinkage, okay? So those are kind of the two FDA approved drugs. And the question that I get most often in clinic, and the thing that we're all talking about, at conferences and in the sort of national tumor boards and things that we have, is the big question is, how long do you take this drug? Right? You have a 44-year-old person, right? Was the average in the trial, and are you going to put them on a drug for life? Right? That's a long time for somebody who probably doesn't have other medical conditions and things, right? You're taking young, healthy people for the most part and committing them to these drugs, right? So the trials never had a set stop date, right? It was take it until it doesn't work anymore or the patient gets tired of it, right? But the reality is you don't want to commit people to a lifetime of a medication, right? And so now there's a lot of interest in the community of trying to figure out how long do you take the drug? And if you stop the drug and the tumor comes back, what happens then, right? If you start the drug again, will you benefit again, right? Because we know from other tumor types, right, aggressive tumor types that metastasize and things, that when you stop a drug and then you try to go back to it, it often doesn't work, right? The cells are resistant. So we were worried about that, especially when we only had one FDA approved drug, right? You don't want to kind of use your one FDA approved drug and then not have something to go back to later, right? So there's a lot of concern about, how long to take it, when to stop it, how long to stop it, how long to take it. So a lot of discussion. And so there was a relatively small phase 4 trial. So phase 4 means the drug's been FDA approved and now we're going to study it after that approval, right? So this was a phase 4 trial where basically it's a discontinuation trial. So they took all the people from Enliven, the study for pexidartinib, and said, okay, for those of you that are still on the drug, do you want to stop it or do you want to continue it? And they let the patient decide. Okay, so the patients who decided to stop were able to stop the drug, and they monitored them and then saw how many people basically had their tumor come back, right? And then what happened when they restarted them on therapy. Okay, so this is a big, busy slide, but just to give you a sense, this was a small group of people. Okay, so only 11 patients decided to discontinue their pexidartinib. Okay, and about so 11 patients decided to discontinue, and then 3 of the patients ended up restarting the pexidartinib, okay, later on, and all 3 of them basically had their tumor shrink again, right, or stay the same size. So I know that this is a very small group of people, but I think this was the first kind of concerted effort to make people a little bit more comfortable with stopping the drug and then being able to restart it later, okay? So we hope to see more of these trials, in the future, just because I think from a practical standpoint, this is a really, really important issue, right, of when to start, when to stop. Okay. All right. So that's pexidartinib, vimseltinib. And then there's another company that basically has another drug that inhibits CSF1, right? So we call these Me Too drugs, right? So when a drug gets approved for one indication, then other companies will make the same drug essentially, or try to make a better version of that drug. So this drug is called pimicotinib. Okay, so it's made by a different company. And they did have a phase 1 trial that was done back in 2023, and the FDA said, we like the results of that trial, we're going to fast track it, right, to try to get it FDA approved faster. So the maneuver trial has happened and is done. It is a phase 3 randomized, double-blind, placebo-controlled, multi-center trial, okay? This was done at 23 centers, and the company tells us that there's a 62% response rate, but we're waiting for the publication. So basically, this is the data that they presented at ASCO. And so again, two patients got pimicotinib, and then to every one patient that got placebo. Okay, and so they say about 92% of people had their tumor basically decrease in size somewhat. Okay, so we do think that maybe this is going to end up being a slightly better drug in terms of, how potent it is and how much response that you get. But that all, is kind of awaiting the final trial results being published. And the side effects are somewhat similar. We do see some of the liver toxicity with this drug. Okay. All right, so let's switch gears. So pimicotinib likely will get FDA approved, so we'll keep an eye out for that and figure out how we're going to sort of, rank these. So, which one?
These pills.
Yes, thank you for bringing that up. Yes, all three of these are pills. Okay, so now we'll switch, actually, that's a good segue into monoclonal antibodies, right? So if you want to inhibit something, right? So CSF1 is something on the outside of a cell. So let's just pretend that this is a TGCT cell, and then all of these are CSF1 receptors, right? So you can block that with a drug. The drugs actually go inside of the cell, right? And block it from the inside. But you can basically use what's called a monoclonal antibody. So our immune system normally makes antibodies, and these antibodies help us to fight infections, right? Primarily bacterias. And so they recognize certain proteins and they bind to the cells. Okay, so when a cell has antibodies attached to it, that's a signal for the immune system to kill that cell, right? Because it thinks it's bacteria, right? So we can make these antibodies, right? And they're used across cancers. You can make these antibodies to target something on the outside of the cell and basically coat a cancer cell, right? And then that gets the immune system to come in and kill that cell. Okay. The other thing that it does is basically, if this is the CSF receptor, right, it has to basically pick up like what's called a ligand, right? So there's a little protein that comes and binds here to activate this, this receptor. But if you have an antibody attached, it can't bind, right? So you're kind of doing two things, right? You're blocking the way that the CSF1 receptor works. You're blocking it from taking up the thing it needs to be active. But then you're also coating the cell, right, with these antibodies to tell the immune system to kill it. Okay, so monoclonal antibodies have come a long way. They're used across a lot of cancers. And so a company basically said, well, let's make a monoclonal antibody to CSF, right? And so the first company to do this made a drug called cabiralizumab, okay? And they did a phase 1 and 2 trial. So as you can see down here, this is what I was trying to explain, is that, we have these CSF1 receptors, and they have to take up the ligand, right? This little CSF1 to be active. And so you can basically block that with these antibodies, okay? So the phase 1 trial was actually done back in 2016 for this drug. And then the phase 2 was completed in 2021. The data still hasn't been published. Okay, so this company, 5 Prime Therapeutics, basically got acquired by another company. And the other company is probably not going to move forward with the development of this drug. Okay, so that data is probably not going to be seen. But as you can see down here, there's another drug called imictuzumab. Okay, so this is another monoclonal antibody made by a different company. Okay. So this antibody had a phase 2 trial that was done. And this is looking at people's MRIs, right? So again, this is a waterfall plot. So as you can see, all the patients that were treated with imictuzumab, right, a lot of them had their tumors shrink, right? So this data looks promising in the phase 2. And so this has moved on to phase 3, but just as a segue to what you mentioned earlier, or your question earlier, is monoclonal antibodies, because of their stability, they're not pills, right? These are IV infusions, okay? So they're almost all given once every 3 weeks, okay? So you would have to go into an infusion center, right? Get an IV placed, get the drug. And For some people, that can create some logistical issues, right? It's nice to just stay at home and take a pill. But the side effects of these monoclonal antibodies tend to be a little bit better. People don't tend to notice quite as many side effects when they have the monoclonal antibodies. The caveat here is that there were several side effects in the phase 2 trial. But when we talk about side effects, we talk about, are they on target effects or are they off target effects? Okay. So an on target effect means it's just doing its job, right? It's blocking CSF1, and because it's blocking that, you get side effects, right? But an off target effect means it's blocking CSF1, but it's also blocking all these other things that are causing side effects, right? So the hair color change that we see with pexidartinib is because the drug actually blocks a different receptor called c-KIT, right? But in this case, we do see several side effects in the phase 2 trial that we also see with the pills. And that's because these are on target effects, right? This is the drug doing its job. It's blocking CSF1, but for whatever reason, this causes issues with the face and swelling, right? But it's because it's blocking CSF1. So you can't get around some of these side effects, even with the antibody, okay? And antibodies tend to be much more specific, right? So it probably is just blocking CSF1 and not other things, as compared to the pills are always blocking something else, okay? So we do see some of the same side effects that we saw with some of the other pills. Okay. But now the TANGENT trial was to study imictuzumab. And again, phase 3, randomized, double-blind, multi-center, placebo-controlled trial, right? So comparing drug to placebo. This trial was interesting because it actually allowed people to have previously gotten pexidartinib, which was the first trial that really allowed that, okay? And they said that it was okay as long as you hadn't had the drug in the last 3 months, okay? So they did allow prior treatment, okay? We're awaiting the results of the TANGENT trial. Most of us think that it will get FDA approved. So it will be nice to have that as an option as well. Okay. All right. And then switching gears a little bit, it would be, the dream drug, right, is a drug that basically you don't have to treat the whole body, right? You don't get the eye swelling and all of these other things, right? You directly treat the joint, right? So this company developed this agent, AMB05X, right? And there was a clinical trial that was open. This is a CSF1 inhibitor being injected directly into the joint, okay? So the idea was don't get all the side effects throughout the rest of the body, right? Just put it where you need it, okay? Unfortunately, this trial was closed early and likely because of toxicity, okay? And that we were seeing the drug being functioning throughout the rest of the body, right? But we'll have to wait to see if they publish that data to find out the details of this. But I really hope that more of these drugs are, developed and that we can figure out better ways to kind of hold the drug in the joint because obviously this is the ideal, right? Okay. So there are other drugs currently in clinical trial, nilotinib, which is a drug that is, again, developed for something else, but has been shown to have efficacy in TGCT. And then there's another antibody, another Me-Too antibody, right, coming down the line. So we'll keep an eye out for those two. And then what's really coming down the pipeline, like what's in the lab, right, that we're excited about. So there is another inhibitor that's probably more specific that has been tested in TGCT cell lines in the lab, and it looks promising. So that will probably move into clinical trial, early phase, right, a phase 1 trial. And then there's this whole idea that maybe we don't have to shrink the tumor. Maybe we can block the inflammatory pathways, right? And so there are drugs like infliximab and etanercept that are used for inflammatory conditions like rheumatoid arthritis, right? Crohn's disease. And maybe we can use those in TGCT and help people to feel better and improve their symptoms, right? And these drugs are pretty well tolerated, right? And they're used in a lot of patients, so we know a lot about them. So there's some interest in that. And then there's also this zaltoprofen, which is basically ibuprofen's stronger cousin to help to treat the pain and maybe impact the tumor cells as well. Okay. All right. So that is all that I had to say. So happy to take questions, or maybe we can just start the panel, Laura?
Start the panel.
Okay.
We're gonna wait for Dr. Copenhaver as well.
Okay.
I can
Okay.
do that.